Good morning, ladies and gentlemen. The topic of today is the urinary system and mainly kidneys. The urinary system serves for excretion of waste products from the human body. The urine, its product contains water, ions, and nitrogen molecules like urea, creatinine, ammonium, and so on. And for this serves as a parenchymatous organ kidney and a system of the ducts. The main functional unit of the kidney is called nephron, and the nephron is composed of glomerulus of capillaries and then a system of tubules, which then continues as a system of ducts. And finally, these ducts come out of the parenchyma and forms a hollow system of the kidney, composed of minor, major calyces and renal pelvis. And the renal pelvis leaves the sinus of kidney as a ureter. These organs are paired. When the two ureters join into urinary bladder, which is unpaired, then we call this part already a lower urinary system, and the urinary bladder then continues as a urethra outside of the body at the perineum. So that's for the overview, and we start with the kidney, which is called renis in Latin, and nephros in Greek. This organ usually weighs some 150 grams, and its dimensions are 12 by 6 by 3 centimeters approximately. We can describe on a kidney anterior and posterior surface, as you can see the anterior here now. We can describe superior inferior pole, and on the superior pole you can actually see the suprarenal gland. And we can describe medial and lateral margin, and on the medial margin you can nicely see this concave part, which we call sinus. In sinus, there's located hilum, as in every parenchymatous organ, and this hilum contains three main structures, and they are arranged ventrodorsally as a renal vein, renal artery, and renal pelvis. Of course, you can see that the vein has got tributaries, the arteries got branches, and the pelvis is formed by minor and major calyces. Except for these main structures, there are, of course, nerves and lymph vessels, which are not shown in this figure. As it's a parenchymatous organ, it has a fibrous capsula on the surface and inside the functional parenchyma. And we can divide, of course, kidney in a smaller units. And we have two classifications. One is a developmental into lobi and lobuli, which is of no functional use in clinics. And the other is into 5 segments, which is very important concerning the blood supply. So I will come to this later. So when we cut the kidney in a frontal plane, we can see the internal structure. The internal structure is a bit general, so we can find the capsule on the surface, as I said, and then a cortex and a medulla. Cortex is lighter and granular. So you can see the cortex here, the cortex, granular and darker. Medulla is lighter and granular. Medulla is darker, striated, and form so-called pyramids. And these pyramids, they are terminated medially by so-called papillae, which protrudes into minor calyces, and the papilla has a dotted or perforated surface, which is called area cribrosa, and the openings are terminations of the hollow system of papillary ducts, so we call them papillary foramina. So that's the major arrangement, the cortex and medulla forming pyramids, opening at a papilla with papillary foramina, and altogether the foramina are called cribriform area. We can see overlapping of the cortex and medulla. So the cortex protrudes into medulla as so-called columns, renal columns, and the medulla protrude into cortex in so-called medullar rays. And the medullar rays forms these striations. So these striations, these are the medullary rays. The medulla itself can be then divided into two zones, internal, external, and the external into bands, internal and external. It's not visible on this figure. We come to this closer when we talk about a nephron. Then in the sinus, you can nicely see the pelvis formed by two calyces, calyx major, and then it's formed by 7 to 14 minor calyces. The number corresponds to the number of pyramids. The kidney as an organ is located in abdominal cavity in its upper part, so it's lying on the diaphragm, so it's in the diaphragmatic wall to right and left. As you can see, the right is a little bit lower than the left due to the position of the liver here. All the urinary system is located retroperitoneally primarily because it develops here from intermediate mesoderm mainly. And the kidney is covered by adipose tissue and of course by connective tissue in the form of renal fascia. So we come to this. Please, this is a figure you should know how to draw. It's a transverse section of the posterior abdominal wall. So it contains, of course, the lumbar vertebra number 1. It contains deep back muscles, which are here. It contains psoas major muscle, quadratus lumborum, latissimus dorsi, and 3 abdominal muscles in the lateral wall. You can see pancreas and duodenum, ventrally, and on the sides ascending descending colon. And of course, nicely you can see a kidney. In the middle, red aorta and blue inferior vena cava. So we can see also the renal sinus with renal hilum. And now the covers. The kidney itself is covered by capsule, renal fibrous capsule. And around kidney, you can find a fat pad, which is called adipose capsule. So number 4 is adipose capsule, or a synonym is perirenal adipose fat pad. So adipose capsule or perirenal, which means around the kidney, as you can see. Then the whole kidney with the incoming and outcoming vessels and renal pelvis and the other kidney. All the structures are covered by renal fascia of a Romanian anatomist working in France, Gerotta. So this Gerotta's fascia has got two plates, anterior and posterior. And these two laminae or two plates, we can nicely see. So number 2 is the prerenal one, called Tolz, and the postrenal called Zuckerkandels. Yeah, they were Germans, and Tolz even worked in Prague. So this fascia with 2 layers encompasses the kidney, and it's closed above. So it also encompasses the suprarenal gland. You can see it's closed laterally, but it's opened medially as the vessels can enter it. And it's also opened caudally as the kidney during the development ascends. It's very important for the clinics in case of really hard starving. When the adipose tissue is reduced, then the kidney can be released from its position and can travel caudally, which we call a migrating kidney. Yeah, and it's due to the opened side of the renal fascia based on the development. So during the development, the kidney ascends, and it can migrate downwards again in case of starving, heavy starving. And then around this fascia, so mainly dorsally, but also laterally, we can find another fat bed, which is called pararenal fat bed. So please do not mix perirenal, which is around the kidneys, also called adipose capsule, and pararenal, which is outside the renal fascia. As you can see, everything is located behind peritoneum. So, as we said, the kidney is located in the upper part of the abdominal cavity, quite dorsally, behind peritoneum, and its relation to many organs. And all of these organs are in front of the kidney. So, to operate the kidney, it is not easy. Either you have to go between the organs, or you have to go from the lateral side, extraperitoneally, which is preferred. And that means that you go through the muscles and you go here extraperitoneally and you can access it. So what impressions we can see on the anterior surface? So on both sides we have the suprarenal glands. Yeah, so we have the suprarenal glands impression here. On both sides, on the lower pole, we have the impression of colic flexure. So right colic flexure or hepatic on the right side, left colic flexure or splenic on the left side. Corresponding to this, we have impression of liver on the right side and a spleen on the left side. And then when we have impression of the spleen, then also the tail of the pancreas is located in the hilum of the spleen. So we have impression of the pancreas. And then on the left side, we have to add also stomach, because stomach is on the left side. So gaster. And what is then remaining here is the jejunum and ileum, which is this area here. Sorry, only jejunum here. So the colic flexure is here then above. So the inferior pole is colic flexure and jejunum. The superior pole is suprarenal glands. And then on the right side, we have to add liver. On the left side, we have to add spleen and stomach and pancreas. And on the right side, there is very small part in touch with duodenum. So if we have some recesses, then the Morrison's pouch or hepatorenal recess can be located just here in this area. From the posterior aspect, there are no organs, but other structures which are in close contact. Mainly, it's diaphragm, so upper 2/3 are in contact with diaphragm. And the lower 1/3 is in contact with perpendicular muscles. So you can see the muscles here above. So as I said, it's psoas, I'll just change the color. It's psoas major, quadratus lumborum, and the deepest abdominal muscle, transversus abdominis. So you can see them also here, psoas major, quadratus lumborum, and transversus abdominis. Yeah? So dorsally, just muscles. But because there's a diaphragm, Behind the diaphragm, don't forget that we have the pleural cavity. So the pleural cavity is between the diaphragm and the ribs. So which ribs are in contact with kidney, and which ribs fractures can harm the kidney? 11th and 12th. So the three ribs. And what is again important are connections with peripheral nerves. And it's the last thoracic nerve, so the subcostal, and it's the first lumbar and the second lumbar nerve level. Although, of course, the iliohypogastric originates also from T12. So these three nerves are in contact. So if there's an inflammation of the kidney, it can irritate the nerves and can cause pain in the corresponding dermatomes. So these are the relationships of the kidney to the anterior and posterior wall. And now we can slowly continue to the internal structure of the kidney. So the main functional unit is nephron, and number of nephrons is around 1 million. The nephrons are quite complicated structures composed of glomerulus, which is a convolute of capillaries, and then a system of tubules. Between nephrons, the space is filled with interstitium. The interstitium is composed of fibroblasts, myofibroblasts, lymphocytes, macrophages, and interstitial peritubular cells. And then, of course, we have a system of the vessels which branch here and bring blood. So now we will concentrate on the nephron parts and on vessels. So the nephron is composed of system of tubules, which are green here. Then it's composed of this, which is called renal corpuscle, and it's a sac filled with capillary loops. And then a structure which is not shown here, but I will just mark it. And it's located here. And it's called juxtaglomerular apparatus. When juxta means close by. So these are structures between the distal tubule and the afferent and efferent arterioles of the corpuscle. Yeah. So that's just the overview, and we come now closer. So you can see how it's arranged. So first we have the renal corpuscle, which is this sac filled with loops. Then from the sac starts a tubule, which is called proximal one. And the proximal starts with a convoluted part, and then continues as a straight part. Then it gets thinner, and it's called intermediate tubule. And the intermediate tubule descends down. So you can see that we are now in medulla. So what's located in cortex? It's only glomerulus and convoluted part of proximal tubule. In medulla, we have straight part of proximal tubule and the whole intermediate tubule. So both descending and ascending limb. Then it gets back and it's again larger. So then we call it straight part of distal tubule. So you can see that proximal and distal tubules are larger. So their diameter is thicker than the intermediate tubule. And then it gets back into cortex. So the cortex is again containing a convoluted part of distal tubule. So in cortex we have glomerulus, so the renal corpuscle, and convoluted part of proximal and distal tubule. Then finally, the distal tubule changed into a very small, very short connecting duct, which is called in Latin tubulus reuniens. And then these collecting ducts merge and they form collecting tubules. So the communicating duct, communicating tubule then forms this, or sorry, connecting tubule forms this collecting tubule. And you can see the collecting tubules is located again in medulla, and it's in the medullary ray. So what is shown here is that the medulla extends into cortex, as I said before, and forms medullary rays, and the rays contain these collecting tubules. And the collecting tubules, when they come really downwards into internal zone of medulla, they are larger and they form papillary ducts, and the papillary ducts open the papillary foramina into minor calyx. So this is the system, and based on location of the straight parts of tubuli, we can divide medulla into 3 zones. So the internal zone contains only intermediate tubule. When it comes to external zone, the external zone already contains the larger parts, so the straight parts of both proximal and distal tubule. And to distinguish them, the internal band contains the distal tubule straight part, and the external band contains straight part of the proximal tubule. Well, it's very complicated, as you can see, so I just try to show you the way how you can approach it. So when we come to the renal corpuscle, how it's formed. So we have an arteriole. The arteriole comes and branches into capillary loops, and these capillary loops then collect, and what is quite interesting, they form again an arteriole. Why arteriole? Because we need the muscle layer of this arteriole to control the blood pressure here, and that means the filtration. Because the capillaries, as we will talk about it a bit later, serves as a filtrating membrane for the fluid. So the fluid, that means the plasma here, is filtrated into this cavity, which is called the cavity which is inside so-called capsule, the glomerular capsule of Bowman. So it's called Bowman's capsule. And in one day, 180 up to 200 liters of fluid gets there. So majority of the plasma is filtered there. So you need, of course, to get it back into the body, because we cannot accept 200 liters of the fluid per day, and we cannot get rid of it. So then in the system of the tubules, we reabsorb the majority of the water back, 99%. And to manage the pressure here, we use the muscle layers of these arterioles as well. Yeah, that's why you have an arteriole here. And it can remind you of another system of the body, intestine and liver, concerning the blood vessels. So we have 2 capillary beds, which are in a series. So here we will have also another capillary bed. So that's why here is located an efferent arteriole, an afferent, and an efferent one. So when we come closer to the corpuscle, you can see here a scanning electron microscope view, and the larger vessel is the afferent one, and the narrower one is the efferent arteriole. Because the efferent arteriole is narrower, it forms the pressure on the blood coming, and that's why the plasma is filtrated in the convolute of capillaries. And there is about 30 of these capillaries, and they are highly anastomosed. So, and I move here, we can again see the larger afferent arteriole here and the narrower afferent arteriole. So where these two arterioles come and start to form the 30 capillaries, we call this a vascular pole. The capillaries are covered by podocytes. We will come to them later. And then is a cavity, which we call a Bowman space, or capsular space. And then it's all covered by this Bowman's capsule. The Bowman's capsule can be called a parietal layer, and the podocytes, which are here on the surface, we can call a visceral layer. And this space, the Bowman space, is filled with the primitive urine, with the 180 liters of the primitive urine. And then it leaves the capsule into a convoluted part of the proximal tubule. And this part we call a urinary pole of the renal corpuscle. So the glomerulus is the convolute of capillaries, and the Bowman's capsule or renal corpuscle is the whole structure. The capillaries are fenestrated, and the fenestrations are quite large, up to 100 nanometers. And there is no diaphragm in these fenestrated capillaries. So it's a specific type of capillaries just here in the kidney. As I said, the Bowman's capsule or Bowman's pouch contains a parietal sheet, which is formed by flat simple epithelium, and a visceral sheet, which is formed by podocytes. Why these cells are called podocytes, I will show you. They have two generations of processes called trabecules and pedicles. And the space in between, as you can see here, are free spaces. They are not free, they are filled with mesangial cells. Here you can hear mes, which means between, and angion, which means a vessel. So these cells are in between, and they produce also an interstitial structure which is called mesangial matrix. But their function is to be phagocytes, to remove a waste which can be entrapped here. They are contractile, so they can move a bit the loops of capillaries, and they are mitotically active. So when we come to the real filtration barrier, you already know the blood-air barrier in the lungs. So this is quite similar, blood-urine barrier with 3 layers. So we have endothelial cells in the capillaries. We have podocytes on the other side, but only their processes which are called pedicles. And if you remember, in blood-air barrier, it was formed by pneumocytes type 2, but just their very thin parts, not the centers with the nuclei. And in between are fused basal laminae into a basement or basal membrane. So of course it's composed of 2 laminae rare and 1 lamina densa. And lamina densa contains several important proteins. And I think you should remember here is a collagen 4, as the collagen 4 forms a physical net for the filtration. Concerning the endothelium, I just repeat that we have the fenestrations without the diaphragm, and of course the cells in the fenestrations, the wall of the fenestrations contains proteins which are anionic. It's very important, as we have also some other anionic proteins in podocytes. We can talk about the nephrine here, or podocalycine, which is in the anionic glycocalyx here. And all these anionic charge is here to stop anionic proteins of plasma to be filtrated. Even these proteins are quite small, so they can pass through the fenestrations. This anionic charge stops them and prevent them to enter the urine. Otherwise, we have to again get them back. Of course, some of them can go through if they are small, but then they are internalized by proximal tubule cells and they are absorbed. But we cannot do this with all the amount of proteins, which is 60 milligrams per liter per milliliter in plasma, so it's too much. So that's why we have this anionic barrier. So the substance charge, which is anionic, and the final size of the openings, which is 25 nanometers, allows only water and low molecular substances like creatinine, urea, and then amino acids, glucose to pass. Yeah, so not plasma proteins and not, of course, blood cells, white, red blood cells, thrombocytes. So if you look at some figures, we can see podocyte, and the podocyte has got larger and smaller level of processes. So we can see these trabecules, and these trabecules then gives these small processes which we call pedicles. And only these small holes, which you can see in between, are the filtrating slits. So here is just shown that there is no space between the vessels in the glomerulus, between capillaries, and that the space is filled with mesangial matrix and mesangial cells. Why to know about these cells for clinics? Kidney often suffers from glomerulonephritis, from an inflammation, but this inflammation is usually autonomic, and it can affect not only the capillaries, but it can also affect the mesangial cells. So we can have a mesangial glomerulonephritis. So it's important, or glomerulonephropathy, and you have to then understand which cells are affected. When we come to a histological slide, we can see the tubules we are going to talk about in a minute. So these are the tubules. That's the parietal layer of the Bowman's pouch or capsule. And this is the space where the primitive urine is collected. We can see an efferent arteriole here, and the nuclei of the mesangial cells and the mesangial matrix. And the other spaces then left here are capillaries. We can see here the proximal tubule leaving the glomerulus. So this is the vascular pole, and this is the urinary pole, and the proximal tubule. This is a distal tubule, and the proximal tubule here is filled with quite larger cells, which will then absorb majority of the fluid and smaller molecules. And this stands for interstitium, which contains, as I said, fibroblasts, myofibroblasts, lymphocytes, macrophages, and peritubular cells. A scanning electron microscope shows us nicely the filtration barrier, where you can see the basal membrane, the endothelial cells, and pedicles of the podocyte. The podocyte nucleus is shown here. So this first is the trabecula, and then the small ones are the pedicles. So then the fluid has to go this way. So from the blood it goes into the urinary space. And again, a detail here, So it just goes from the capillary into the Bowman's capsule. So I talk about the mesangial cells. It's important to distinguish two kinds of mesangial cells, intra and extraglomerular. The extraglomerular are located at the juxtaglomerular apparatus. I'll come to this later. And we have just talked about this intraglomerular one. They can remind you of a pericyte, as every capillary has got a pericyte. So this also works as a pericyte. So that's why the function is so complex. So again, to repeat, it's a contractile function. And this contractile function is sensitive to two hormones. One you already know, and it's the natriuretic, atrial natriuretic factor produced in atria of the heart in case the atria contains too much fluid, so they are extended. And the myocyte, cardiomyocytes in the wall of atria produce the natriuretic factor. And natriuretic, it means that in the urine is more natrium content and the sodium content. So then, of course, you void more natrium, more fluid, and your blood pressure goes down. About angiotensin, I will talk. These cells, they produce the mesangial matrix, which is filling the spaces between them, and the collagen. And too much of the collagen then in the autoimmune inflammation produces the glomerulopathy. Of course, they serve for phagocytosis, as I said, and they are mitotically active. So again, when they are too mitotically active, it again produces the glomerulopathy. So that's all for renal corpuscle, and now we move to tubules. The renal tubules consist of proximal, intermediate, and distal tubule, as I said before. The intermediate tubule is the thin part, which is shown here. And the proximal tubule and distal tubule has got two parts, convoluted, which are in cortex, and then the straight parts, which are already in medulla. The convoluted part can be divided into three segments based on the type of transporters which are here, but this is the part of physiology, and I do not go into details now. And the convoluted part of the distal tubule is very close to the renal corpuscle. So here we have the juxtaglomerular apparatus, and the cells which are part of this apparatus are called macula densa. I'll come to this again later. So this is just the introduction. And now let's talk about the proximal tubule. You can see on the section of tubule that there are few cells with this microvilli border brush. So the epithelium here is quite high. It's cuboid, of course, it's simple. So on the luminal side, we have microvilli, so the brush border. And on the other side, on the basal side, we have a basolateral labyrinth, so many folds. And it's there because of the Na plus K plus ATP pace. The function of this transporter is to actively pump sodium out of the cell into the interstitium and exchanging it for potassium. This means that then from the fluid, the sodium is transported passively into the cell. And when we have this concentration gradient, it also takes water. And that's the main reason how we reabsorb the water and ions from the primitive urine, and we can save majority of this fluid. The same way works for amino acids and glucose. So we have here a cotransporter on the luminal side for sodium and glucose. So it's a facilitated diffusion process. So again, by the ATPase on the basolateral side, we pump actively sodium into interstitium. So it takes sodium on the luminal side passively in, and this co-transporter takes not only sodium but also glucose or amino acids. So it's very, very clever system. The cells has to be rich in mitochondria, so they are quite large, and their cytoplasm tincture is more basophilic. So when we come closer, you can nicely see the brush border and just a few nuclei, yeah, 5 to 6. And when we come here to scanning electron microscope figure, then you nicely see the nuclei, which are in the center. You can see the striations here, yeah. On the basal side, here is a capillary with red blood cells. And of course, mitochondria, many mitochondria located in the basal part. On the luminal side, you have the system of microvilli, so the brush border. So this is just to show you how the cell is really arranged. So when we come from the external band or stria externa of the medulla into internal zone of medulla, we come to descending limb of intermediate tubule. The intermediate tubule is part of the Henle's loop, and I will explain the Henle's loop in a minute. But the intermediate loop tubule, as you can see, is totally different. The cells are flat. There are very few organelles, and it's because of the descending part is permeable for water only, because we have a special channel for that, which is called aquaporine. And when it turns up back and starts to ascend, it is not permeable for the water. I will explain why this a bit later. Some of the neurons has short, some of the neurons has long intermediate tubule. Again, I will explain that. And this arrangement forms something which is called countercurrent system, as we have tubules with urine in one direction and tubule with blood in the other direction, so that means blood vessels. And these moving fluids change the concentration of the ions, so it forms a constant gradient from urine to blood. The details will be explained in physiology, and I come to some of the details a bit later. So what is the Henle's loop? You can see here. The Henle's loop contains the whole intermediate tubule, which is descending and ascending limb of the intermediate tubule. So from here to here. So you can see that in the internal zone of medulla, we have only the descending and ascending limb, which are thin, so the intermediate tubule. Then we have the thick ascending limb of the Henle's loop, which is corresponding to straight part of the distal tubule. So if you look here, it's this part. So when we add this, then we call it the external zone. And the last part is corresponding part of the proximal tubule. So again, the straight part. So the straight part of the proximal tubule is then called the thick descending clip, and it then corresponds to the external band or stria externa of the external zone. So again, just to review, the Henle's loop or Anza-Nefroni is composed of three morphological parts. Intermediate tubule, the whole one, forming the thin ascending and thin descending limb, which we find in internal zone of medulla. Then it's composed of straight parts of both proximal and distal tubule, which form the thick limbs. And the distal one forms the ascending thick limb. So then it's located in the external zone, but in internal band. And the proximal tubule forms the thick descending limb, which is located in the external zone, but in external band. So yeah, it's a bit complicated, and the reason why to do it is to allow the ions and the water to get out into interstitium and then to be taken away by vessels. So this forms the counter-current system. So what happens first is that the ions get out. So I'll just change the color. In proximal tubule, the ions get out. Then here the water gets out. But then in ascending loop, it's not permeable for water, so no water out. But still ions get out. So that means that the interstitium is now full of ions. How to get the water then back? You can see that the distal tubule then goes into the connecting tubule and then in the collecting one, and we are in medullary array. So the collecting tubule then descends in medulla, and the medulla is full of ions. So then again, the water gets out here, and it's saved in collecting tubules. So that's the way how we save first ions and then water. And all this is then absorbed back in vessels. And the amount of urine is only 1 to 1.5 liters. So again, we can see it here. First ions, then water. No water here, but still ions. So high concentration on ions. And then when it comes back to collecting tubules, in collecting tubules, again, water in the interstitial fluid. But as I said, the details will be explained in physiology. So again, here to show that we have a cortex. The cortex forms so-called labyrinth and medulla can be divided into external zone with two bands, external and internal, with a straight part of proximal and straight part of distal tubule, and internal zone containing intermediate tubule. And don't forget about these medullary rays, and the medullary ray contains a collecting tubule. Nice histological slide shows you the system of all these tubules. You can see here mainly thin-walled structures. So these thin-walled structures are intermediate tubule. Then you can see here arterioles and venules. And why in these structures there are no erythrocytes? I will explain that a bit later as well, but that's quite interesting. And then you have these larger tubules, which are collecting ducts. And we can see here also a straight part of the distal tubule. So this section as you can see, goes through medulla, but through the external layer, but through external band of this layer. So come to distal tubule. Distal tubule also contains simple cuboid epithelium, but the cells are not so high. So there can be more of the cells, not only 5 to 6, but can be like 7, 8, or 10. There is no brush border. There are some microvilli, but not a real brush border. But of course, there's the basolateral labyrinth with sodium, potassium, ATPase. So again, they are rich in mitochondria. So the main function here is resorption of sodium. As I said, we need to get more ions into interstitium here. But in distal tubule, it does not work automatically, but the ATPase is managed by aldosterone. Aldosterone is a hormone of suprarenal gland of its cortex, and I will come again to this hormone later in juxtaglomerular apparatus. The distal tubule contains some cells of the juxtaglomerular apparatus, and they are called macula densa, as the cells are a bit more packed, so they looked darker in the light microscope. And the function of macula densa is a chemoreceptor, so it tells you how many sodium and chloride ions are in urine, and then it affects secretion of hormones, and finally secretion of aldosterone. So the distal tubules is both chemoreceptor and a place where the hormone produced by a system of structures involved in this process finally functions. So it starts in distal tubule and it terminates in distal tubule. So when we come here, we can see the proximal and distal tubule difference. So the cells in proximal tubule are higher. There are not so many of these cells. In distal tubule, they are lower. And we come here again to scanning electron microscope. So you can see very few microvilli, so no brush border, but of course so many mitochondria here, a nucleus, and basolateral labyrinths of the striations are also visible. So that's the cell of distal tubule. And finally, we come to juxtaglomerular apparatus or juxtaglomerular apparatus. As I said, juxta or juxta means close by. So it is formed, as you can see here, by distal tubule. And in distal tubule, special cells, which are called macula densa cells. There are about 30 of them, not necessary to know the number. They have a reverse polarity. That means that the nuclei are not basally, but they are apically, and they serve as chemoreceptors. Then, what is close is afferent and also sometimes afferent arteriole. So the other cells of this system are cells of the tunica media. They are specialized smooth cells, and they are called granular because they contain granula. They contain granula of enzyme, or sometimes called hormone, but it works as an enzyme called renin, produced in kidney. These granular cells not only produce renin, but they also serve as mechanoreceptors. So these granular cells, to release renin, they get two informations. One is from themselves. When they are expanded by higher blood pressure, they start to produce renin. And when they are informed from macula densa about too high level of sodium or chloride ions in urine, these cells of macula densa, because they are not in close contact, they inform the cells which are in between. They are not shown here in this figure, but they are in between. And they are called mesangial cells, but not intraglomerular one, which are between podocytes and endothelial cells, but extraglomerular mesangial cells. They are also called Lassis cells or Guttmacher-Tye cells. And their function is just to connect the cells of distal tubule, the macula densa, and the cells of arterioles, the granular cells. They just transmit the information. And what the renin does? The renin starts an axis which is called renin-angiotensin-aldosterone system axis. And the function of the axis is to change the blood pressure and the volume of the urine which is excreted from the body. So let's come to this in a detail. First, morphologically, in distal tubule, you can see the macula densa cells, which are with different polarity. So you can see that the nucleus is located apically, and they are darker. Here they are the extra, next to it are extraglomerular mesangial cells or Lassis cells. We just transmit the information to cells of tunica media of the arteriole, which we call the juxtaglomerular or granular cells, which then release renin into the lumen. And where does the renin goes? Again, to show it here. Macula densa cells with the higher polarity, they are darker than the rest of the tubule, as you can see here. The rest of the tubule is not so dark. Then the extraglomerular cells or Lassis cells, and then the granular cells in the wall of the arteriole. So that's the whole juxtaglomerular system, which produces renin. So what can happen? So in case we have decrease of the blood pressure, which can be due to decrease of the blood volume, dehydration, or hemorrhage, what happens? Lower blood pressure means that the mechanoreceptors, the granular cells, they find out that the blood pressure is low, so they start to produce renin. Or they are also informed from distal tubule that we have the deficiency of sodium. So the distal tubule, the macula densa, tells them via the extraglomerular mesangial cells that they should produce renin. Renin is an enzyme. It's produced in the blood. In the blood, we have a protein called angiotensin produced in liver. Yeah, it's normal plasma protein. It's there. The renin as an enzyme cuts off parts of the angiotensin gene and produces angiotensin 1. Angiotensin 1 is a very, very weak constrictor on the vessels. So it starts to elevate the blood pressure. Yeah, so it elevates the blood pressure, but just a bit. It is transported by blood into lungs, and on the epithelium on the lungs, we have so-called angiotensin converting enzyme. And the abbreviation is ACE, very important then for clinical medicine. This enzyme on the endothelial cells of the pulmonary capillaries changes, again, it cuts and shortens angiotensin 1 into angiotensin 2, which is a very mighty constrictor. So it starts to elevate the blood pressure. So vasoconstriction of arterioles and blood pressure increases. But it also comes to suprarenal gland cortex, where it starts or elevates production of aldosterone, which is a steroid hormone. And this aldosterone comes to kidney, to distal tubule, so it comes back here to distal tubule, and increases reabsorption of sodium, so it means a water reabsorption. And this increases the blood volume, and the blood pressure gets normal, so higher. So this is the system which starts with renin, continues to angiotensin 1 and 2, and terminates as aldosterone in the distal tubule. And this RAA system, you can see, elevates blood pressure. So in case you suffer from hypertension, you can use different kinds of treatment. So, for example, beta blockers, which works against, which functions on beta receptors in the heart for sympathetic system. So it reduces the work of the heart, so then the blood pressure is lower. Or you can block the ACE in lungs, so angiotensin converting enzyme inhibitors, which are the really best anti-hypertension medicaments. So so-called ACE inhibitors are the medicaments of the first choice to treat hypertension. So you can see we started to study pharmacology in internal medicine now. Yeah, it's very, very important for the clinical medicine, and you have to understand how this axis works, and anatomy gives you the background for that with the juxtaglomerular apparatus. And we can continue further in the kidney and getting out from nephron into already the excretory system. So the distal tubule continues as a very short connecting tubule, or in Latin tubulus hernians, which is an arched tubule which leaves the cortex and enters medulla into a collecting ducts. It contains simple cuboid epithelium. It's nothing special about that, and I think we even can skip this very, very short connecting tubule. What we cannot skip is the collecting duct, or ductus colligans, or so-called Bellini's duct. It's located already in the medullary rays, so they come up from the cortex down, but within the medullary rays. They contain quite high cells, as you can see here, so simple columnar epithelium. And again, it absorbs water, so we can use aquaporins, but different aquaporins than in the descending limb of intermediate tubulus, because these aquaporins are sensitive to a hormone. This hormone is produced in posterior lobe of pituitary gland, in so-called neurohypophysis. It's a very short peptide, so it's an oligopeptide, and it's called antidiuretic hormone. Antidiuretic means diuresis, means the urine you get out of the body. So antidiuretic hormone saves your water. And it's also called vasopressin, as it also constricts vessels. Vessel, vas in Latin, and press, yeah, it's a pressure, you understand it. So two names for one hormone, and this hormone is produced in hypothalamus and secreted in the posterior lobe of pituitary gland based on the osmoreceptors in hypothalamus. So in case you have too high level of sodium, you can feel it in your brain, and you send this hormone directly to the kidney, and it opens the aquaporins, and the water is reabsorbed into the interstitium. So that's the function of the collecting duct, and we can save here 15 to 30 liters of the fluid. If we have problems with this hormone, we suffer from so-called diabetes insipidus. That means that the patients urinate daily 15 to 30 liters of the fluid. So he or she has to drink too much, and it's very dangerous disease. These collecting ducts then continue into the internal zone of medulla, and are then joined into so-called papillary ducts. They are aligned again with the simple columnar epithelium, and they just open at the cribriform area of the renal papilla. So that's all for the renal tubules. Concerning the histology of the collecting ducts, we have two types of the cells. The principal cells, they contain the aquaporin, which is sensitive to antidiuretic hormone, as I said. And then we have darker cells, which are called intercalated. And they contain two ATPases. One is for proton, and the other exchange proton and potassium cation. And these serves for modulation of pH of urine. It's very important to get rid of protons, because the metabolism of the human body produces too much protons, so it's acidifying. So we try to get rid of it. So we try to reabsorb bicarbonate by way of carbon anhydrasis. And the bicarbonate helps us to neutralize the protons. And but there are too many of them, so we try to get rid of them by these two ATPases. So you can see that the body tries to save sodium, so it exchanges sodium in sodium-potassium ATPase. But then we will lose too much potassium. That's why we can exchange the potassium in the urine back, and we exchange it with protons, and we save also the potassium, and we get rid of the protons which we still produce in metabolism. So this is quite clever. So as a whole, we try to save sodium, which takes water, and we get rid of potassium. But again, then later, in collecting tubules, we also save potassium, and we exchange it for protons. The histological slide shows you the longitudinal section of the collecting tubules. So this is a medullary ray, and here we can see glomerulus, and close to the glomerulus an vessel and arteriole. So that was all for the nephrons. And now we move to blood supply. The blood supply of the kidney is easy. We have a paired renal artery branching from abdominal aorta at the level between L1 and L2. The L1 is located a bit higher because on the right side we have the liver, which is larger than the spleen on the left side. The angle between the aorta and the renal artery is 90 degrees. Due to development, we have very often an accessory renal artery up to 30%, and it is usually a branch of abdominal aorta, can be a branch of common or internal iliac artery based on the ascent of the kidney during the development. and it usually supplies the inferior pole of the kidney, but can also enter the superior pole. For physiology, it's important to remember that the blood flow is more than 1 liter per minute. So in some 5 minutes, we exchange all the blood in the human body in the kidney. And very important is that there are no arterial anastomosis. So as the arteries branches, they supply segments which are not connected. So in case of infarction of one of the branches, the part of the kidney can die. And in case of transplantation, we have to take both the renal artery and the accessory renal artery. Otherwise, we will cause again ischemia, necrosis of some of the segment, and rejection of the donor's kidney in the recipient's body. So which segments we have? The renal artery divides into anterior and posterior branch. The posterior branch is very thin and it's only for one posterior segment. The anterior branch is quite thick and it then divides into all the remaining 4 segments. So when I'll come back here, you can see a posterior segment from posterior aspect, which is supplied by posterior branch of renal artery. And then we have 4 segments. 2 of them are visible from both aspects. So we have the superior and inferior segment. And from the anterior aspect, we can see anterior superior segment and anterior inferior segment. So 5 renal segments. This figure shows you the complicated arrangement. So now we have to go from larger to smaller ones, and important is that we have here 2 right angles during the way. So these segmental branches then branch into so-called lobar ones. The lobar ones correspond to developmental parts, and they also correspond to number of the pyramids and number of the minor calyces. These lobar then branch into 2 or 3 interlobar. Sorry, here should be interlobar. I'm sorry for this mistake. Interlobar. And these interlobar comes and branch in vertically running arcuate arteries. And these arcuate arteries run in between cortex and medulla. So you can nicely see it here, the arcuate artery running at the border of medulla and cortex. And again, we will have right angle branching into interlobular arteries. These arteries are also called radiate cortical, as you can see that they really radiate in the cortex this way, yeah? So they are like fan-shaped. So that's synonym, radiate cortical arteries or interlobular. And then from this interlobular, we have already branching the afferent glomerular arterioles. So when I'll come back, you can see here these small afferent arterioles already forming the glomeruli. So they form the capillaries of glomerulus, the 30 capillaries. And you know that the blood pressure is in the renal artery approximately 120 torrs or millimeters of mercury. Here in glomerulus it's 55, so we can say it's half of the value in large arteries. At the end of glomerulus is a much narrower efferent arteriole, and as it's an arteriole, it has to continue again in a capillary plexus. So it continues in a capillary plexus, which is very close to that, to tubuli. So then it continues And you can see here to these capillary plexus, which is around proximal and distal tubuli. And we call it peritubular capillary plexus. But some of these do not continue here, but continue in so-called straight arterioles. And we can see it here. Then in case the glomerulus is not in high in cortex like this, which we call cortical glomeruli, but here these glomeruli are very, very close to medulla, so we call them juxtamedullar, juxtamedullar or juxtamedullar, depends on the pronunciation. So what they have, they do not continue as peritubular capillary plexus, as you can see here, but they continue as the straight arterioles or arteriolar recta, and they just form a loop and go back as a venular recta up. So we have two kind of capillary network. Either peritubular capillary plexus in cortical glomeruli, or the straight ones, arteriolar recta in juxtamedullar nephrons. Yeah. So this arteriolar recta, they run along intermediate tubulus and they form the countercurrent system. The blood pressure in them is quite low. So you can see it's the blood pressure which you can find in the first venules, so only 15 torrs. And it's also important that we cannot get here in these straight vessels, we cannot get erythrocytes. If the erythrocyte is here, the problem is that there is a different concentration of ions, and the erythrocytes would accept too much fluid and would burst. That's why we need to dilute the plasma and get rid of it, erythrocytes here. That's why we have the right angle branching here twice. Yeah? Once it is at the arcuate once, and then it's when the interlobular artery is branching again. So twice we have these two right angle branching, and it diverts the erythrocytes into cortical nephrons, not to juxtamedullary ones, and that's why in arteriolar recta are only few erythrocytes. So again, to review it, arcuate artery, then it branches into interlobular or radiate cortical. It gives afferent arteriole, then we can see the efferent arteriole coming, and the efferent arteriole forms either straight ones, arteriola recta, along intermediate tubulus, or it forms peritubular capillary plexus. So this figure shows you again the same. So we have the arcuate and interlobular, we have the afferent and efferent, and when it's a juxtamedullary nephron, it continues as the straight ones. When it's a cortical one, it continues as the peritubulary capillary network or plexus. So this is the arrangement of the arteries. Concerning the veins, we have peritubulary capillary plexus, and we have straight venules. We also have so-called small stellate veins, which come from the capsule. The capsule is supplied by capsular branches of the interlobular arteries and drained by so-called stellate veins, which really looks as a small stars or small spiders on the surface of the kidney. And then the venules then merge into interlobular, arcuate, interlobar, and finally renal vein draining into inferior vena cava. So to conclude, we have two capillary networks which are serially arranged. Yeah? So we have one in glomerulus, and the second is either peritubular capillary network or vasa recta, the straight ones. Yeah? And this is similar to liver, where we have the intestinal capillary network in the wall of intestine absorbing nutrients, and then we have the liver containing the sinusoids along the hepatocytes, and we call this portal system because of the portal vein, which is in between. So the portal vein is in between in liver. And this term we generalize and we move it also to kidney. So we have here a portal system, and we apply this term also to hypothalamus and hypophysis. We will talk about this later. Concerning the lymph drainage, it's very, very easy. We have three lymphatic plexuses, peritubular and subcapsular are in the kidney itself, and the third one comes from the surroundings, so from the fat pad around, and it's drained to the nearest lymph nodes, so to lateral aortic and lateral caval ones, which belongs to the lumbar group of lymph nodes. The kidney innervation is also very easy. It's similar to intestine innervation, so it's vagus nerve and sympathetic trunk via thoracic splanchnic nerves, mainly minor and imus. Imus is specifically for kidney only. These fibers, the vagus nerves and sympathetic fibers, meet in abdominal aortic plexus, and there's a special small ganglion for kidney, which is called aorticorenal ganglion, and the renal artery is winded by renal plexus. In case the patient suffers from hypertension, which is pharmacoresistant, we can try to apply denervation of the sympathetic fibers in renal plexus. So we just enter the system via femoral artery, and with the catheter we get into abdominal aorta, and we divert into renal artery, and here we apply a warmth, a temperature around 60 degrees for a while, and we destroy the renal plexus. And when there is no sympathetic innervation in the kidney, then the filtration gets lower and the blood pressure is lowered by 20 to 30 millimeters of mercury. So this method is used only in pharmacoresistant hypertension. So now let's talk about the function of the kidney as a whole. So the function of the kidney is to produce urine and the body gets rid of the waste products. But of course, during this process, we have to save water and ions. And for this, we use the countercurrent multiplication system. If you look here, we can see how the system works. And it's similar to the countercurrent system in, let's say, legs and feet of a penguin standing on an ice, or feet and legs of a stork standing in a cold water. As in arteries, the heat is going down, and in veins, the veins go up. So the heat is given from arteries to the veins. That's why they form vascular bundles, one artery and two veins. Yeah? So this system in the limbs saves the heat. Similar system here, but between vessels and intermediate tubulus, or all the tubuli here, so mainly a handless loop, saves the ions and the water. And you can see how the concentration of the urine changes and how the concentration of the interstitium changes, and of course all the ions which goes from the tubules gets into the vessels. Yeah, but this is a topic of physiology, and you will talk about the countercurrent system in detail in physiology. Otherwise, the second year is not necessary for you if I explain it in detail here, and we have no time for that. So that's the countercurrent system. It is regulated by hormones, and we have already talked about all of them. So don't forget about the renin, which finally via aldosterone affects the income of sodium and outcome on potassium. Then income of sodium is on the contrary reduced by A and F produced in heart atria, and the income of water or the reabsorption of water is regulated by antidiuretic hormone or vasopressin in collecting tubule. But the kidney has other hormone function. It also produces erythropoietin in peritubular cells. So based on a lower amount of oxygen in the blood in peritubular capillary plexus, these cells start to produce erythropoietin, which is a growing factor for stem cells in bone marrow. And the cells of proximal tubule, they also work with vitamin D, cholecalciferol. They produce calcitriol, vitamin D3, by hydroxylation in position 25. So it's first hydroxylated in liver, and then in kidney, and then it can work as a hormone, which helps us in reabsorption of calcium, and of course absorption of calcium in the intestine as well. Yeah? So these two hormones are also related to kidney. So the countercurrent system is again shown here, and I'll still talk about mainly sodium and potassium, but don't forget also about urea and ammonium and all the other ions like calcium, because then the final amount of all these ions creates the osmolality of both the urine, interstitium, and blood. So that's all for the anatomy, how to examine kidney in clinical practice. So of course we can try the native X-ray image, but nothing special is seen. So the method of choice is ultrasonography. If we want to see the function of the kidney, we can use the excretory urography. So the patient gets a contrast fluid into blood vessels, and then we can see how the kidney really functions and how the contrast fluid is filtered as a real waste product. If we would like to see the hollow system of the kidney, we use an ascending pyelography. So we administer the contrast fluid via a urethra into urinary bladder, ureter, and renal pelvis. The function can be also shown by scintigraphy scan, but this really shows not the morphology, but only the function. Of course, CT MRI helps us, and a physiological method of examination is called clearance. Clearance means that the kidney makes a specific amount of the blood per specific time period and it's we can measure it on some substances, either the internal substances of the human body, which is creatinine, that's the waste product of muscle metabolism, or we can use some other substances which are inert. So if we get them into the body, we just get rid of them, like para-amino hippurate acid. Yeah? But you will talk about this in physiology again. So that's the clearance, that's the capability of the kidney to clear a specific volume per specific time period, like 100 milliliters per minute or so. So the ultrasound, you see the probe, the wall, so the muscles, and we can get to the kidney capsule and the hollow system filled with the urine. Yeah? And that's the parenchyma. Not only the kidney parenchyma, but also the flow of blood in the kidney. We can image, and we use the renal color Doppler, showing us if the fluid goes towards or from the probe. The scintigraphy shows us the activity, so we use either SPECT or PET. So we can see the activity in the kidneys. Of course, the left kidney is a bit higher than the right kidney, but in the case we can see here, we have migrating or dystopic kidney. We can distinguish the migrating kidney means that the kidney moves downwards in heavy starving because of the opened renal fascia caudally. Or dystopic kidney means that the kidney developed and did not ascend during the fetal period, and it's still located somewhere caudally, either in pelvis or in lower abdominal cavity. But you can nicely see the difference between the location. Of course, CT shows you nicely the kidney in front of the psoas and quadratus muscles, and behind the liver here, and next to spleen here, and close to pancreas. You can see the parenchyma, and here the hollow system with the urine, and a really large stone in filling the whole calyceal and pelvic part. On MRI, again CT, but in the frontal section you can see the same big stone here, so close to the liver on the right side and close to spleen on the left side, and in contact with descending colon here. MRI shows you nicely the parenchyma, again liver and spleen, and here in the parenchyma these small dots are small cysts, which can be functional or developmental defect. So some of the renal diseases which you can know, we have talked about the migrating kidney in case of reducing the fat pad around kidney. We have talked about the glomerulonephritis, which is usually autoimmune and can involve also the mesangial cells. The kidney can be infected from below, so from urethra and urinary bladder. So then it's pyelonephritis is usually connected with fever and back pain. If there are stones in the hollow system, then it's called nephrolithiasis, and it can cause a blockage and real severe pain in the back, which is called renal colic. If the renal colic is not treated, it's painful, but it can cause hydronephrosis, which means that the urine is not removed, is not voided from the pelvis or ureter. It's blocked there, and because the fluid is incompressible, it starts to compress the parenchyma. The parenchyma is reduced, hypertrophied, and it can lead to renal failure. How to treat it? You have to remove the stone. If it's not possible, you have to apply nephrostomy, which is a direct application, percutaneous application of a catheter into the kidney, yeah, from the back or from the flank into the kidney. Diabetes affects the small vessels. So in this case, it affects arterioles, glomeruli, and it causes nephropathy. So patients with long-term diabetes, they have problems with the kidneys as they have problems with retinal vessels and vision. There are two specific tumors which you may hear about in biology. You will hear about the autosomal dominant Wilms tumor, and in internal medicine about Gravid's tumor, which is a very specific tumor because it produces solitary metastasis. So usually one metastasis, quite often into thigh bone. So it can be then more easily treated than the other kinds of tumor. And stenosis of the renal artery will produce a hypertension because less blood comes to the kidney, and the granular cells in juxtaglomerular apparatus will think, oh, it's hypotension, so they produce more renin and cause hypertension. So an easy solution of this kind of hypertension, you apply a stent into renal artery, so you enlarge it, then more fluid comes, and then the renin is not so produced, and the hypertension is solved. Polycystic kidneys is autosomal dominant hereditary disease, and the kidneys at the age of 30 to 40 changes into such a bulk of cysts, and the parenchyma is reduced, and it proceeds quickly into renal failure. So the only solution is dialysis and transplantation of the kidney. Here you can see quite big stones in the kidney. So that's nephrolithiasis, lithos, stone in Greek, and multiple nephrolithiasis in the kidneys on CT, which I think is apparent. The kidney in nephrolithiasis or ureterolithiasis is then affected by hydronephrosis, and you can see here a really reduction of the parenchyma, so it leads to the renal failure. The hydronephrosis can be shown easily by ultrasound, as you can see the dilated calyces and pelvis, and reduced parenchyma here. Just to demonstrate some diseases on histological slides, this structure is glomerulus. You can see here tubule, distal tubule, and the interstitial part, which we just have not talked much about, is filled with lymphocytes. You can see the violet round cells, and you can see also the erythrocytes here. So this is a bacterial inflammation, acute pyelonephritis. On the contrary here, what you can see is different. Here in a glomerulus, there are quite strange substances, and RD here. So in between the spaces, such pathological substances are stored, and it's the microangiopathy. So that's the problem of the arterioles and mainly capillaries here. So then it blocks the blood flow here, and it causes diabetic nephropathy, which also finally leads to renal failure. And the last topic is a quick review of the development of the kidney, because I have still mentioned that before. So kidney develops in 3 stages based on phylogenesis. So we have so-called pronephros, the first primitive one. Then we have a mesonephros, the middle stage, and the metanephros, the definitive stage. You can see it here that it develops not only in the thigh, but also in the space. So the first stage, the pronephros, develop in the cervical part. The metanephros then develop in thoracic part, and the metanephros in lumbar part. And finally, the metanephros ascends. The development is closely related to intermediate mesoderm and also to cloaca, into which then this primitive mesonephric duct of Wolff enters. So the development of the kidney, as I said, is connected, or it happens inside the intermediate mesoderm. So the intermediate mesoderm gets thicker, forms a ridge, which is called a urogenital ridge. So it's this area, and you can see the ridge here, and it's a urogenital ridge, so it produces not only kidney but also the gonade. And for the urinary system, we need this intermediate mesoderm and its part, which is called a metanephric blastema, which then produces the glomerulus and tubules. And then we need a Wolffian duct, which produces a ureteric butt, and this butt produces everything which comes from ureter to pelvis, major and minor calyces, papillary ducts, and collecting ducts. Concerning the urinary bladder and urethra, they are produced by cloaca, urogenital sinus, and surrounding splanchnic mesoderm, but this is a topic of next lecture. Of course, the blood vessels, they are branches from dorsal aorta, so they come from the mesoderm. And don't forget about the neural crest cells, which serves for the nerves. So the pronephros, which are a functional organ of the lamprey, are really very transient, the first structure which appears in the cervical region. And what is interesting, it was first described in humans by a Czech anatomist, whose name you can forget. It's just an interesting note. So this disappears, but it is the starting point for metanephros. So let's come to metanephros, which works as a kidney organ in sharks and some kind of fishes. And it is produced in thoracic part. And let's look how it looks like. Here above we will have the pronephros, but they phase out. So this first primitive system, which looks as a glomerulus and a short tubulus connected to subcardial vein, then it produces such tubules, and these tubules merge in one descending duct. This duct is called mesonephric duct or Wolffian duct, according to a German embryologist Wolff. And this Wolffian duct finally grows into cloaca. How the Wolffian duct is produced? You have just vacuoles, and these vacuoles merge, and finally they produce a duct. And from this duct, ureteric butt outpouches. So then the mesonephros are not necessary anymore, and they should fade out, but they stay, and the Wolffian duct here, it then produces the deferent duct in males. and its caudal part produces all the hollow system of the kidney. So, as I said, ureter, pelvis, calyces, and collecting ducts. Close to it is a gonade, and as the gonade descends, it takes the mesonephric tubuli and the Wolffian duct down as far as scrotum. That's why then the Wolffian duct can serve as a deferent duct. So that's the Wolffian or mesonephric duct. So I just conclude that it originates in intermediate mesoderm by apoptosis, forming vacuoles. These vacuoles, they merge into one duct. It's a continuation of the pronephros, so of the pronephric duct. So it originates cranially as a cul-de-sac. Then it grows down into cloaca, and the lower portion then forms a butt, a ureteric butt, which outpouches and grows into the future definitive kidney, so into metanephric blastema. And the Wolffian duct then produces the excretory part of the male genital system, so the deferent duct. Yeah? So you can see that then it produces really this, which is the deferent duct, as far as the prostate, and its outpouching is also the vesiculous gland or seminal gland. So the Wolffian duct produces a part of urinary bladder, ureter, renal pelvis, major and minor calyces, papillary ducts, and collecting ducts. In female, there are only developmental rudiments. And in male, of course, the excretory urinary system plus the excretory genital tract. That means mainly deferent duct, but also the duct of epididymis and the duct of vesiculous glands and the vesiculous glands itself. So, and concerning the real definitive kidney or a metanephros, it is produced in the lumbar part, in the lower lumbar part. That's why it relatively ascends. Relatively ascends means that the trunk really grows and gets longer and longer. So the kidneys are moved up, and they are stopped at the level of superior mesenteric artery, because at the level of the superior mesenteric artery, the kidney arteries, which are to the sides, they just meet the superior mesenteric artery origin, and they cannot ascend up. So they stop here, so they are finally at the level of L1. As I said, what is important is the ureteric bud, which grows into the metanephrogenic blastema. It induces the growth of the nephron, and finally they fuse together. And it's functional already from the 9th week of intrauterine development. So here you can see the ascent of the kidneys, the relative ascent. You can see also that the kidneys are contained of developmental lobuli. And you can see also in the lower part the development of the blood vessels, which finally supply the kidney. Here, just to show the difference between the male and female Wolffian and Müllerian duct. So we have talked about the Wolffian mesonephric duct, yeah, which is paired, opens into cloaca here down. And in female, or in both sexes, we have another duct which is called paramesonephric duct or Müllerian duct. This duct is produced by coelomic epithelium, which is internalized into the intermediate mesoderm. So that's why when it's internalized, it starts as a pouch from it. So that's why here we have the connection. And this connection will then be finally the opening of the uterine tube in females. The inferior parts of the mesonephric duct, they fuse together. That's why we have one unpaired uterus, and they open also in cloaca. In males, the testis produces so-called anti-Müllerian hormone, and this anti-Müllerian hormone inhibits the development of the Müllerian duct, so the Müllerian duct totally disappears in males. So in females, it's important because it produces uterine tube and uterus and a bit of vagina. In females, it totally disappears. And the Wolffian duct, as I said, it produces the excretory ducts, excretory urinary ducts, and in female it disappears, and in male it produces the deferent duct and adjacent ducts. So I said the definitive location and the function starts in the 9th week. Then the number of glomeruli slowly increases up to 1 million. The fetal kidneys are divided into lobes, but this division disappears during childhood. And there are some developmental defects you should know about. They are mainly shape defects. And patients with shape defects can have normal functions, but they can also suffer from reduced function. Yeah? So in case you have this shape, you are prone to the heart failure sooner, but you can live normally. So the shape can affect, but may not affect, need not affect, can affect or need not affect the function. So which are the shapes? This is the developmental shape. So that's during fetal development. You can find this in dolphin and bears, but not usually in humans. If you see this in an old person, it usually means an atrophy of the kidney due to age. And then the kidneys can fuse. They can fuse right and left with the inferior pole. Then we call it arcuate or horseshoe kidney. They can fuse not only with the lower, but also with the upper poles. So then it forms so-called fungiform in Latin. In English, it's called cake or pancake kidney. And the aorta goes in between here. So it can sometimes compress the inferior vena cava. And it can fuse on one side, then we have a doubled kidney, or it can fuse inferior pole of one and superior pole of the other. So then we have these S-shaped or sigmoid one. So this concerns the shapes. Of course, we can suffer from renal agenesis. The renal agenesis means not that even the urine is not produced during fetal period, and the urine is avoided into amniotic fluid, and the amniotic fluid is swallowed by the fetus, and it's important for development of the lungs, as you know. So in case of renal agenesis, we have also problems we have oligohydramnion, and we have problems with the development of lungs as well. We can have an ectopic kidney in a different position. In Latin, it's called a dystopic kidney, and I showed you before the scintigraphy scan that it can be located in the pelvis. Don't forget that in pelvis, we can find also a transplant kidney. So a kidney in pelvis can be either dystopic or ectopic or a transplanted kidney. Kidney can feature cysts, which I showed you on MRI, small cysts, or they can be polycystic, as I said, autosomal dominant hereditary disease, which needs then dialysis and transplantation. So what we can see here is a ectopic kidney and a bit rotated, because during the development, the hilum rotates from ventral position to medial position. Yeah. So here are two kinds of the ectopia. You can see in ectopia, of course, the vessels comes from the closest source. In case of migrating kidney, the kidney takes the vessels from the origin, so the vessels prolong. In here you can see different shapes, mainly the horseshoe kidney or the cake or pancake kidney here, or change in the rotation of the kidney that the hilum is located ventrally. So that's all, folks, for today. Thank you very much for the attention and have a nice day. Bye-bye.